All right, and welcome to Your Brain and Pain. And we're going to talk about advancing pain care from the 17th to the 21st century. And I'm your host for this, Dr. Kevin Kukar. We'll go over my background a little bit here. But we have about 4 different things we're going to talk about. The first thing is sort of the not-so-secret secret of pain in healthcare. How well do we actually do in our healthcare system when it comes to caring for pain? Then we're going to talk about 2 key concepts when it comes to pain. The first one, what's the purpose of pain? Why do we actually hurt? Why is it that we experience pain? Because everything that we have in our brains and bodies, there's a purpose for. So pain has a purpose. And unfortunately, though, we sometimes misread that or we have some misconceptions about that. So we'll talk about what the purpose of pain is. And then the second thing that we're going to touch on is the most common misconception about pain that almost everyone makes. In fact, it's kind of the default there. But when we think in these terms, how it can make pain very challenging to treat, and also puts a lot of limitations on how we care for pain. And then lastly, we're going to just touch on very, very briefly on some different thinking when it comes to pain and moving away from the idea of managing it and more toward a mastery mindset. So the overall goal for this presentation, though, is to make sense of pain, any pain. Now, that's the goal. That's the end result. Will you come out of this presentation with the mastery level understanding of pain that everything completely makes sense? Probably not. That doesn't necessarily happen in a 1 hour talk, but what it can lead you on is a path. This is the start of thinking differently about pain, being able to kind of thinking about your own pain, your family members' pain, your friends' pains a little bit differently, so things start to make sense. So again, the goal is to make sense of pain, whether it's a new pain, old pain, pain that's been there for 20 years, pain that's just happened 20 seconds ago. Will it make it completely clear? Probably not, but at least when you'll start that journey here. Again, we have about an hour. We can't teach everything there is about pain, but we can provide a very good foundation that makes sense for individuals, and hopefully helps you to take a little bit different approach if you are someone who experiences pain on a daily or near daily level. We're also going to talk about questions versus statements. What I mean by that is I'm going to be saying things when we're talking about pain. We have a lot of stuff wrapped around it. And so if you hear something and it kind of gets you activated, we start touching these belief systems. And when we touch belief systems, they have a tendency to get activated. And when a belief system gets activated, we react. And so our heart starts to get up, we start getting some feelings in our stomach, things start twitching around, and we feel kind of uncomfortable. If that happens, that is okay. But what I need you to do, instead of speaking in a statement of, Dr. Kukaro, you're a complete and utter idiot, that can't be true at all, period, is change that to a question mark. A Dr. Kukaro, that can't be true. Are you an idiot? Question mark. Because if we have that sort of question mark at the end, it means we can have a dialogue and a conversation. Statements do not allow us to have a discussion. And unfortunately, if we're not talking about things, we're not revealing some questions and thinking about things, nothing's going to change. So if you have a reaction, that's okay. That's just telling us that our little pain belief systems are getting activated there. But frame those into questions. Be willing to question those internal belief systems rather than act in statements. The other thing is, if you have a pen or pencil and a piece of paper, that would be good. I wouldn't recommend that you take notes per se, because I would rather have you focus on what I am talking about here. Instead, use that pen and pencil to write down questions. There's a couple parts in this presentation I will ask you to actually write something down. And then if you are following the presentation, and again, instead of taking notes, write down a question. If there's a particular slide, you can try to put down the slide number, and that'll help for reference. So who am I to even talk about this stuff? Why are you guys on a webinar in the middle of the day to talk about pain? And particularly, what are my qualifications in order to do so? Well, I'm Dr. Kevin Kukaro. I'm what you would call a typical pain-trained physician, meaning I did a residency in University of Chicago in anesthesia. We obviously did a lot around pain, both in the OR and out of the OR. I did a fellowship in pain medicine at the University of Michigan. I was a military physician. They had paid for medical school, and so it was in Naval Medical Center, San Diego. And after we created a pain fellowship program down there, I was the associate program director of the Naval Pain Medicine Fellowship Program. So working in and around pain, but all of that training, you cannot have any more training than I have when it comes to pain in the healthcare system. And at the end of the day, what I recognized pretty quickly is we learned a lot about injections, but pain still didn't seem to make sense very well. Meaning we would have people coming into our clinics in the military and again, we had a catchment area that was entire Pacific rim. So we saw young people with pain. We saw older people pain, back pain. We had people who had, arms and legs that had been lost in the war. And it was very frustrating because we were kept doing lots and lots and lots of injections. And it was very hard to determine who got better and who didn't. In fact, we sort of would just do things and then see if people got better. And you could do the same procedure on two different individuals with the same quote unquote pain and have completely different outcomes. Now, for myself, I thought that might have been the atmosphere that I was in. In the military, we obviously have deployments. You don't have what we would call continuity of care. I may see a person, one of my colleagues, good people, but trained differently, may do procedures that I didn't think were the right procedures for them. And so there's all this discontinuity in care, and I thought it was the military. So when I left the military, I came up to Oregon. At the time, there were no other full-time pain specialists in my location now. I'm in Corvallis, Oregon. And so very shortly, I can practice the way that I was trained to do, the way that my institutions said was the best way to do it. I practiced by the book, by the evidence, by all the guidelines. And within 6 to 8 months, my outcomes were no different than what I was seeing in the military. Again, you could do the same procedure on two different people with quote unquote the exact same pain and have completely different responses to it. So something didn't make sense there. And so I started asking this question of why aren't people getting better if we're doing the things that we're supposed to be doing? And first thing I started looking at was all the procedures and interventions and fancy things that I was taught. Found some things that were shocking that we'll talk about today. And that made me go back as a board certified fellowship trained pain specialist and say, maybe if I'm not getting the outcomes that I'm looking for when it comes to pain, if we have this discontinuity between how we treat it and these completely unpredictable results, maybe I need to actually go back and look at pain. And when I went back and started studying the science of pain, that fundamentally changed my practice. Now, I do consider myself now a pain specialist. I do mostly consulting. I work with healthcare system and mostly with clinicians because you guys are sort of the tip of the spear here. And a lot of the information that you're going to learn, there are very few physicians that actually know this information. The incorporation of modern pain science into clinical practice is lagging about 20 to 40 years behind the science. Because of my work, I've been involved with the state on different levels, a clinical innovation fellow for Oregon Health Authority. I'm on the state pain commission. I've been on numerous regional and state task forces. But the biggest thing up until COVID is some of us as clinicians started working and doing community presentations where we would do talks like this one, except we did them live, and we would rotate throughout different communities here. And then we also had people who were going through some pain programs that were created by students of mine and having fantastic results. And then we started bringing in them to talk to their communities about their outcomes, where people would have, in some cases, 10, 20, 30, 40, 50, 60 years of pain. And instead of managing it, we're really living these full lives, just really had gone into this mastery journey here. And they started giving these presentations. And that's been my most proud moment, is to see the community get engaged. Unfortunately, COVID obviously has stopped those particular presentations, but there was a community organization that has been recently incorporated just before COVID called the Oregon Pain Science Alliance, and they're kind of eager and waiting to the point where we can start doing those presentations again, because they have so many community members who want to talk about their experiences and what they've learned about pain and how it's changed their lives. So how many of you guys know this individual here? So this is Dr. Ignaz Semmelweis. He was a physician in the mid-1800s. An interesting individual. He was an obstetrician, so he delivered babies by training, and his first job out of practice was at the Vienna General Hospital, which was a hospital predominantly for the poor in Vienna. And what he noticed very, very quickly after starting is there was one side of the hospital, one wing that was the medical student and physician side, and the other wing of the hospital was the midwives. And what he found was that women who were delivered by the midwives died less frequently than those who were delivered by the medical students and physicians. Now, childbirth then was very dangerous. Now, it's still dangerous now, but it was very, very dangerous back then. So it wasn't uncommon for people to die. But when you have 2 to 3 times as many people dying when you are admitting them as compared to what we can almost call a control arm, much, much less deaths, there's a problem there. And so he was frustrated by this. So this was pre-germ theory. So we didn't know about bacteria, viruses, and any of these things. And they didn't understand how disease processes worked very well. So they thought things like, well, maybe there's evil humors, bad humors, maybe it's in their blood, etc. And he designed these protocols where they would open the windows to get rid of the bad humors, and he found that the women still died. They closed the windows to prevent the bad humors from coming in, and the women still died. And he kept doing these interventions, and none of them were working very well. And then a tragedy occurred, and the tragedy was a colleague of his who was a pathologist, because this was the golden age of dissection. And what they would do is, between cases, they would dissect the dead bodies and learn about anatomy. And one of his colleagues, who was a pathologist, was doing a dissection and cut his finger, and within a week he died of a disease process that was virtually identical to the disease process that the women were dying of. And so Semmelweis said, wait a second here. He cut his finger, and he had a disease that looked very much like the disease that these women are dying from. So he thought, well, maybe there's this thing called corpse particles. Again, they didn't have germ theory then. And he said, well, maybe we need to wash our hands. So he instituted a hand washing protocol. And what happened was the death rate plummeted on that side. It plummeted on the medical side, so much so that they actually had fewer deaths. And in 1 month, they had no deaths at all on the medical side, as compared when they had been losing many, many patients before they did this hand washing. And so he went out to his colleagues and said, women are dying. And everybody knew that, but we need to wash our hands, because when we washed our hands, the women stopped dying. There's something going on here. And you would think his colleagues would have rushed and said, yes, this is great, you have data. But instead they said, no, we are gentlemen, and they threw him into an insane asylum. Because you have to remember, at this time, pre-germ theory, he was putting forth an idea that was not well known to his physician colleagues. It was actually challenging the idea, because at this moment, back then, physicians were high social status, kind of the lower members of the aristocracy, kind of. And how dare he say that their hands were dirty like someone's hands out in the fields? They were gentlemen, by goodness, and you're not gonna, you can't say that they have dirty hands like someone common field labor. So they protested. Dr. Semmelweis was driven out of the first hospital, went to another hospital, instituted hand washing. Again, death rates plummeted. Was driven out of that hospital. Over the years, he got more and more distressed, started publishing lots of rants and letters saying, hey, we got to do something. We're killing all these women. And then his physician colleagues at some point said, you know what, we got to do something about Semmelweis, and said, hey, Dr. Semmelweis, why don't you come and check out this insane asylum, and you can give us our thoughts on it. They walked in the door with him. They locked it behind him. They were involuntarily committing him. When he tried to leave, the guards beat him so bad that he died 2 weeks later due to sepsis. He had a blood infection. It was over 20 years before hand washing techniques were widely incorporated into medical practice. And so the lesson here was that assumptions and misconceptions can be harmful. When we assume to know without actually knowing the evidence or science behind something, actually questioning those assumptions and making sure that we have data to support them, and particularly in the medical space, there can be some really deadly consequences to it. So what does this have to do with pain and pain care? Well, one of the things that I find really interesting is when you look at the news, they'll kind of use this word between opioids and pain so frequently here. And they'll say, oh, we have the opioids, and then we'll do a pain conference. And if you actually in the physician space, most of the events that are called pain conferences or pain training are all around this opioids. But really, do we have a problem, with this opioids, the opioid epidemic and everything else? Is that the root cause? Or is it because people have pain that we prescribed all these opioids? And really the reason that we have so many people on opioids and have been writing opioids for long is because of pain. Pain is universal. Pain is ubiquitous. Everyone's going to experience it. It's a common presenting symptom. In fact, most people, when they're going to see their healthcare provider, are doing it because of a pain or distress-related complaint. If you look at the reasons for disability, Social Security disability, 3 of the top 5 reasons for disability under the age of 45 are pain-related. Back pain, neck pain, other musculoskeletal pain, and then the other 2 being anxiety, depression. We're spending huge amounts of money on the treatment of pain, $600+ billion in direct and indirect expenditures on the treatment of pain, making it the most expensive condition of treatment in the U.S. healthcare system, more than cancer, more than diabetes, more than cardiovascular disease. And the Institutes of Medicine in 2011 published a number saying that we have over 100 million Americans with the treatment of who have pain. Now, if you look at back pain, second most common reason for all physician visits behind cough, cold, and congestion, lifetime prevalence rate between 60 and 90%. Basically, if you have a back, you are more likely to have pain at one point in your life. Similar to if you have a head, you're likely to have a headache at least once in your life. And it's, again, ubiquitous. Almost every culture, anybody with a spine is going to have back pain, and we see it throughout the world. There is no country or continent without back pain. And yet what we do see is the disability rates are very, very different. When you see people disabled with chronic low back pain, it's a disease of the industrialized world. United States, Western Europe, etc., Australia. What we don't see is the disability in industrialized or developing nations. In fact, what seems to be really interesting here is that as you increase a modern healthcare system, the amount of back pain disability seems to increase as well. And they saw this in the Middle East, which went from a really kind of industrialized nomadic culture. Then with the introduction of the oil wealth, within about 10 years, they started having modern healthcare hospitals, modern healthcare techniques, et cetera. And over about a 10-year time frame, the amount of back pain and chronic back pain skyrocketed as well. So why is this occurring? Other ways to look at this when I'm talking to my physician colleagues is I like to remind them that of the direct care options that we have, we can count them on one hand. Meaning if someone walks into our offices and says, "Doctor, you must do something to me," there are only 4 things that we can really do. 1, we can look at them. So we can order x-rays, CT scans, MRIs, et cetera. We can do lab work. We can poke them, which means we can do procedures. The injections, epidural steroid injections, facet injections, medial branch blocks, all that stuff. Surgeries for pain, we can cut you or refer you to a colleague of ours that does that, or we can drug you, meaning we can prescribe opioids or other types of analgesic medications. Those are the only things that we can do to someone directly. And when those are the tools in your toolbox, you tend to use them quite a bit, particularly when you have a distressful problem like pain. MRIs for non-specific low back pain, where every single evidence-based guideline says to not do them, increased over a 300% in a 10-year time frame. Procedures, the things that I was trained to do and what I taught other doctors to do, increased over 130 to 700% depending on the nature of the injection. Surgeries for back pain increased 300% in a 10-year time frame. Some of the most complex information or the complex surgeries increased about 1,500% in a 5-year time period. These are really complex fusions, and go through your front, do your back, do multiple different vertebral levels, etc. Huge operations increased 1,500%. And then opioids. Between 1996 and 2004, the number of opioid prescriptions written increased 690%. Between 2004 and 2011, the number of prescriptions written doubled. But that was the number of prescriptions. The actual amount of opioid increased 1,448%. So not only were we writing more prescriptions, massive amounts of more prescriptions, the amount of opioid per prescription increased massively as well. So much so that the United States being about 4% of the world's population and was consuming over 80% of the world's opioid supply. Now, what did we get for all this stuff? Well, we actually have higher rates of disability now to pain than ever before. We have increasing complication rates. So with the procedures themselves, so are the procedures as dangerous as surgery? Probably not. But there were people getting paralyzed, having nerve injuries, having infections in their spines. In 2012, there was tainted steroid. A bunch of people got fungal infections in their back that were injected in their backs because of the steroids that they were using were tainted. Surgeries for back pain, again, increased dramatically. I have a friend who just recently retired as a spine surgeon. He was seeing 2 to 3 patients a week that when he was looking at their imaging, their MRIs and x-rays, et cetera, before they'd had an operation, he was saying these people should never have had an operation to begin with. Massive amounts of money, which everybody needs to be concerned about. It's not that the U.S. healthcare needs more money. We spend more money, we have more money in our healthcare system than any other nation on the planet. What we need to be looking is what are we spending our money on, and are we getting the benefits from that? And when it comes to pain, we're not seeing it because we're not seeing improvement in self-reports. We're not seeing people get better. In fact, when I talked about that number, 100 million Americans, well, if you go back 10 years before that, so let's look at where we're starting from. US population in the year 2000 was 282 million. We had between 45 and 50 million people estimated to have chronic pain at that time. By 2010, the US population increased to 309 million. That's a 9.6% increase. But over 100 million people estimated to have chronic pain. Well, that's a 122% increase in the prevalence rate of chronic pain. And if that happens at the end of more and more treatment, you got to ask, are we doing something wrong? Does this make sense? And for me, that doesn't. In fact, if I was with a medical student or a resident and they were saying, hey, we're treating this and the person's getting worse, the first thing I would do is say, stop. And the second thing I would do is, well, okay, well, what is it that we're treating them for? And how are we treating them? One of those two things is wrong. Either we don't have the diagnosis correct or we're treating it in the wrong way. And so this really comes down to, well, what is pain? Why is it that we experience it? What's the purpose of pain? Because if we don't understand, again, what we're treating, and we're just kind of throwing things against the wall, then we're going to get results like that. We're not going to see things get better because we don't truly understand it. So let's talk about pain. And so what I'm going to ask you guys to do is find your chat box here. And when I flash this picture, I want you to tell me whether or not the individual is experiencing pain or experienced pain at that time. So like this gentleman, that's a steel-toed boot. That's a 7-inch spike driven through the middle of the shoe or the boot. His foot was in the boot when the nail went through it. So the question is, did he have pain or did he not have pain? And when you kind of look at this and you read the case report, this guy absolutely had pain. He was screaming in pain. He jumped off. He was a builder, jumped off a low wall, got the spike through his boot, hit the ground. He was screaming, taken by an ambulance to the emergency room. In the emergency room, he received fentanyl, prescription fentanyl, not the illegal kind, and a benzodiazepine as a things like Valium or Versed, which is what we call decreases anxiety. He got those two medications. And it was only when he got those medications that they can actually touch the boot and he wasn't screaming. And then they chopped off the boot, and lo and behold, what they found was that the nail was between his toes. So if we were live, I would ask you guys all this again. Did he or did he not experience pain? And some people will say, well, he didn't experience pain. And I go, well, that's interesting, because this guy was screaming in pain. His heart's beating, his blood's pumping. And as a physician, if you give someone a lot of opioids and you give them another medication in addition to that, we're at risk of causing respiratory depression. That didn't happen to this guy, despite getting really powerful opioid medications. So he had pain, and it was 100% real pain. But what he didn't have is he didn't have tissue damage. So then you're like, well, how in the world would you have lots and lots of pain but no tissue damage? That doesn't seem to make sense. Well, how about this gentleman here? So that's a nail, and that is driven through his thumb. And the story for this individual, he was a builder. He was using a nail gun. It was his 4th day on the job. And while using the nail gun, he shot the nail through his thumb. Now, I pulled this off of a video that I found, and very quickly after he did this, someone pulled out a phone, and they were recording this whole thing. And he went and found his colleagues, and and the rest of the video was them trying to get this nail out of his thumb. And what is very interesting is this individual had pain, but he didn't receive any fentanyl. He didn't receive a benzodiazepine. He wasn't even taken to the emergency room, or else it didn't sound like that. Instead, they were laughing and joking around him. And they basically pulled the nail back, cut the head off the nail, and then pulled it through his thumb. And so, yes, he had pain, but he didn't have this excruciating pain like the guy before. But what he has, as compared to the other gentleman didn't have, was tissue damage. Now we have acute tissue damage, and we have less pain than the guy who didn't have tissue damage. Something doesn't seem to be right the way we typically think about pain. Or how about this? A lot of people or a lot of physicians will order x-rays. Let's find where your pain is coming from. Well, if that's true, if x-rays show pain, then we should be able to look at these x-rays and tell who is and who isn't experiencing pain. And that isn't true. And any physician who has actually looked at the data would understand this, because on the left-hand side of the screen, you can tell that these two images aren't the same. The image on the left is what we call lumbar scoliosis. There's a curvature there. His low back from the bottom of his ribs down into his hips has this twisting curve to it. Now, if you're really good, you can actually see an area where there's what we would call post-operative changes, where someone has gone in and they've gone what we call and they've debolted, they've actually taken off parts of the bone here, usually if there's some sort of stenosis with that. The image on the right of the screen, though, is a pretty normal looking x-ray. Now, this is not a 5-year-old's x-ray. So just like on the exterior, we look older as we get older. So like for myself, I have more wrinkles on my forehead. I have less hair on the top of my head. I may have different coloration on my skin based on sun exposure and things like that. But on the inside, that happens as well. So you get wrinkles on the outside, you also get wrinkles on the inside. And so this x-ray demonstrates somebody who's got a spine that's not 5 years old. It's got some age-related change with it. And by this point, you should recognize we can't tell who has pain simply by looking at this. The image on the left, the one with the scoliosis and the decompression surgeries, is actually someone I know personally. He's a physical therapist. He was born with congenital scoliosis. He was born with these changes. He had that surgery as more of a neurologic sparing. As he grew up, he needed to have the surgery done, but he has never had back pain. And yet he had this twisted spine. Well, the image on the right isn't my patient, but I use it as an example of someone I saw in the military. A young man whose back, quote, went out one day on the boat and then had horrible back pain. All his imaging came, quote unquote, normal. We were really frustrated because we didn't understand why he was still hurting. He was on high-dose morphine, and yet his imaging looked pretty simple. And so the question then becomes, and we need to be able to answer is, how can someone have severe pain in their foot, yet there's no foot spike through their foot? Have a nail in their thumb, but really little pain? Actually have spinal deformity, but no back pain? Or you can have normal x-rays, but a tremendous amount of pain. And we need to be able to explain this rather than to say, well, they are or they aren't, or this person's lying and that person isn't. Because one, it's not true. None of these individuals were lying. And two, it adds this judgmental aspect in there that somehow we have some pains are real and other pains are not, when we all know that if you're experiencing pain, you're experiencing pain. You're not making it up. So we need to be able to define and describe this. How is it? How is it that pain can change so easily and so frequently and has all these variables to it? And the one thing that we seem to notice, though, when we look at the definition, is there's more to it than we typically think about. So the International Association for the Study of Pain had a definition they published in 1979. This is a pretty decent definition when we kind of break it down, saying that pain is unpleasant. No one likes pain. We don't want pain, but it serves a very important purpose. And this purpose, this experience that we have, has both the sensation, like what's the characteristics, is it hot, cold, what area of the body it is, and then there's this emotional aspect, how awful, how unpleasant it is. And we perceive this experience within our body. And that experience may or may not have tissue damage associated with it. There is no reason you can have pain with tissue damage, i.e. a broken bone, and you can have horrible pain without tissue damage, without a broken bone. Now, if we take that definition and we accelerate it over about 20 more years of pain science, we can sort of condense it a little bit more, and we see that pain remains unpleasant. Again, has the sensation element. There's something that we perceive within our bodies, and it has this emotional element to it, this unpleasantness, the awfulness associated with it. But what really defines pain is that we have this experience and it's defined in bodily terms, and this experience changes with perceived danger or threat. So when there is danger, then we experience pain. Because what the purpose of pain ultimately is pain is all about protection. Why we hurt is to protect ourselves. So what then changes pain, I'll ask you in a little bit here, isn't damage. It's not a damage indicator. Now, will we have pain if we have a nail through our thumb? Yes, usually. Or will we have situations when we don't have pain with a nail in our thumb? Yes, and we'll talk about those in situations. Because what changes is not the damage, but the perception of what we think of threat and danger. Because how else would something like this make sense? Now, think about it. If you had a steel-toed boot, what is that designed to do? It's designed to protect your foot. And if you were jumping and you hit something and all of a sudden you felt something different, you felt something different in your foot, and then you looked down and you saw this spike coming through your boot, that's a lot of danger your brain's seeing. Your brain, and there's a sensation that's different than normal, because now you have something that you feel between your toes. Lots and lots of danger there. If that happened to me, I'd be like, oh my gosh, what's happening to my foot? I need to protect my foot. Now, on the opposite side, though, the guy with the nail gun, what I didn't necessarily say is this is a very common injury around people who use nail guns. When I'm doing this presentation live and I ask, there's almost always, depending on the size of the audience, someone who's done something similar, who's shot themselves with a nail gun. Well, if you've done something to yourself, if you've had damage in the past and you've successfully recovered from it, generally, if it recurs again, you already have those past experiences. You know you recovered. You know, hey, this isn't the greatest thing. This kind of sucks, but I'm going to be okay because the last time this happened, I got better. In the absence of that, the people around him had similar injuries. And so rather than, oh my God, you're horrible, you're going to lose your thumb, they were laughing and joking, saying, well, when I did it, it wasn't a big deal. Why are you being such a baby? So their exterior actions diminish the sense of threat with this. Now, if you're a parent, most people have seen this, because if you have watched and you had young kids running around and they're running and they smack into the ground and they can hit pretty hard, and luckily they're kind of rubbery and they bounce a little bit. If they haven't had anything really profound, but they hit with enough force that they're shocked, when they look up and they get on their hands and knees, who's the first person they look to see? And they're looking for their parent or caregiver to see what the reaction is. And if you are going, oh my God, are you okay? A lot of times they'll burst into tears because there's a lot of danger associated with that. But if the parent is saying like, hey, you're okay, looking at them, kind of evaluate them, a lot of times the kid will just look up, brush off their knees and go on off their pain, because there's not a lot of danger. They're not seeing a lot of danger because their protector, their adult, their caregiver, isn't reflecting that sense of danger. So as we increase or decrease the sense of threat and danger, that changes pain. And this has been demonstrated in many, many different types of studies. One simple one, if any of you have had a bruise and you're like, where in the world did this bruise come? And you can't remember, well, now you've had tissue damage, because that's what a bruise is. You've damaged the blood vessels and it oozes the blood out in the periphery there, but you don't have an experience of pain associated with it. Or the pain was so brief it didn't lock into your memory and it's gone. So distraction can be a very powerful modulator. If there's something else that's more important to you than what's going on in your body, that distraction can actually pull your attention away, and because there's no danger, no pain. Now, we have to be able to explain the extremes, though. Remember, I'm a military physician, or I should say I was a military physician. And you hear these things about people who have injuries in the middle of a battle, and yet they don't experience pain. And we got to be able to explain those rather than just to write them off and say that there's something else. Some people, well, it's the adrenaline. The adrenaline blocked all that pain. Well, the guy with that boot, with the nail through his boot, I guarantee you he had a ton of adrenaline going through his body. His heart rate was beating. He was breathing fast. The blood was pumping all into his muscles because it's all this threat and danger. So it's not adrenaline that blocks pain. But when you think about pain as a protector, and now you put someone in a situation where there is a life or death event, in that particular situation, pain is no longer a protector. It would be a distractor. And so our brains and bodies have evolved in such a way that if there is, in fact, even tissue damage, we will not experience pain if we are in a life or death event. And this is a good thing. So, 100,000 years ago, we're running across the plains and the saber-toothed tiger bit our leg. Rather than simply screaming and being helpless, our brains and bodies can now at least generate a response where we can try to beat off that saber-toothed tiger. And then whether or not we experience profound pain afterward depends on lots of different variables. In a modern day variant, if we always experience pain every time we had tissue damage, we would be helpless in a lot of scenarios. You're walking across the street, the light you have the green walking light and you're walking across, you roll your ankle. You've now twisted your ankle. It's a pretty bad sprain. But then you look up and you see there's a Mack truck that doesn't see the stoplight and is bearing down on you. I guarantee you in that scenario, you're going to be able to move as best you can to get out of the path. You will not be incapacitated because of this experience in pain. Because in that moment in time, again, it would not be a protective experience. It would be a distractor. And so our brains and bodies have evolved in such a way to help us to modulate this stuff to make sense to keep us alive. Now, in other experiences, when we start changing beliefs, now, if you believe something is more harmful or not, would that have an impact on your pain? And the answer is yes. So one of my favorite studies was they took hot and cold metal bars, and they had a group of individuals and they said, hey, we're going to take this hot metal bar, we're going to put it against your body, tell us when it gets too hot, so it's uncomfortable, and then tell us when it becomes too painful and you want us to remove this hot metal bar. And what they found was then you put hot metal bars against somebody, they were uncomfortable pretty quick, and they became painful pretty quick, and they wanted them off. And then they said, well, thank you very much. We're going to do another study, same thing, but now we're going to take very cold metal bars and touch them against your skin and tell us the same thing when they get uncomfortable and when they get too hot and you want these metal bars removed. And they found that cold metal bars are also uncomfortable and do become painful, but they're less uncomfortable and they are tolerated longer than hot metal bars. Now, what they had changed, though, was just the words that they were using, because in both scenarios, the bars were very, very cold. Because when you feel something that's very, very cold, what occurs? You have a sensation of burning. So what they were changing was the beliefs behind it, because we have learned over time, and rightly so, that things that are hot and burning tend to be more dangerous than things that are cold and burning. We have less time associated with hot and burning things as compared to cold burning things. Now, you can also have pain without harm when we increase sense of threat. Again, not so high that life or death, but the more you see something as dangerous, the more protection that you perceive, the more pain that you can experience. So if you were in next to a pool, and the reason they don't want you to use glasses around pools because the glasses shatter, and now you have people with bare feet and lots of glass shards everywhere. And if that had occurred, and then you looked over and saw your sandals on the other side, and now you have to inch your way across that pool side, I guarantee you're going to be very, very sensitive to sensations coming up from your feet. If you stepped on even something sharp that may not break the skin, you're going to notice it. You're going to be more likely to construct an experience of pain very easily because of all that danger. That's a dangerous environment, and you're paying lots of attention to your feet because they're in a very dangerous space. Other ones, if I was talking to physicians, I would expand us on more, is the expectations of harm and vulnerable expectations. If you expect pain to occur, or if you believe an area of your body is potentially vulnerable, it's a weak area, that there's already something wrong with it, so it needs extra protection, we're more likely to experience pain with it. This they also did in studies where they did lasers, and they put lasers in people's skin, and they said, hey, we're going to put a laser, tell us when it gets uncomfortable and too painful. Oh, by the way, this area of your body is very vulnerable to lasers. And when they added that phrase, and they would do the same area between different people, but they added that phrase of this area is particularly vulnerable to lasers, people who heard that and had an expectation of vulnerability associated with the area had more pain and faster than those who did not. So they were manipulating what that sensation means. And we already talked about belief of harm with hot and cold metal bars. So what you're seeing here is, again, that pain isn't about damage. Is damage important to an experience of pain? Absolutely. But damage is only one of many types of threats out there. And those other potential threats that we sometimes don't think about, the words, the actions, the meanings, the expectations, what else is in our environment, what we heard, what we expect to occur, all that stuff has an important interplay in any pain, whether it's a new pain, you just broke your leg, fell off the horse, or if it's a pain that you've had for 10, 20 years. Again, because pain is about protection. And that's why we can see these completely different images. Someone who's got a twisted up spine and all these operations because they had congenital scoliosis, yet they don't have any back pain. But somebody else who has normal imaging, who someone would say, this person shouldn't have pain. If, the person who doesn't understand pain says, this person shouldn't have pain because their x-ray is normal. That wouldn't make sense unless we understand pain as a protector, because now we go, wait a second, his back looks okay. But what are the other threats involved here? What does this particular pain, what is it trying to protect this particular person from? And so I've sort of revealed this already, but if the purpose of pain is protection, again, pain is not a damage indicator. We have abundance of data that's saying pain does not linearly increase or decrease with pain or with tissue damage or the absence of tissue damage. What could that primary modulator be? What is the prime mover that we're looking about when it comes to pain? And again, I've said it a couple times, but you can't just write it down because we'll reflect on that at the end. So key concept number 2. Key concept number 1 is that pain is about protection. Key concept number 2 is all about, well, how does it do that? How does pain protect? And again, reflecting back to our assumptions. And so rather than assuming things, let's challenge our assumptions just like we should have done with Dr. Semmelweis in the 1800s. And the assumption is this. This is common language that we use. But where is the pain coming from? So this guy has the nail through his boot, but remember, he doesn't have it. This is between his toes. You could do the same kind of feeling if you put a pencil between your toes. That would be the same feeling that you had. But where is his pain coming from? Again, he had horrible pain. We gave fentanyl in the emergency room, benzodiazepine with it. But where is his pain coming from? And we can't say it's his foot because that doesn't make any sense. There's no damage there at all. All he has is something between his toes. So where is his pain coming from? And the only answer that makes sense is his brain. That this experience, this sensation and emotion all coming together is in his brain. Now, when we look at this individual, though, with the nail through his finger, and we say, well, where is his pain coming from? And people say, well, this pain must be coming from his thumb. But is it? Because if it was coming, again, unadulterated, if it was like little pain particles and a flow of pain pus oozing out of that thumb with the nail in it, going straight up to your brain, then he should be having pretty bad pain. And the other guy who's got the nail through his boot should have no pain at all. So his pain is also coming from his brain. Now, he's got sensory information coming up from his thumb to his brain, but that input, those little inputs saying, hey, something's changed in the tissues down here, that input is not pain. That is just one piece, one component, one danger signal that's involved with how his pain is constructed. But his pain is ultimately created in his brain and has to be in order for it to be this dynamic protective process that it is. And so when we're looking at x-rays and things like that, where is the pain coming from here? Again, we see is, well, this doesn't make sense. If you're thinking about pain coming from oozing like paintbrush out of a structure, doesn't make sense, because now the structures themselves, big structures with scoliotic backs with operations on them, they have no pain. This doesn't make sense. Another way to think about this, if pain oozed like pus out of the body, it would be super easy to treat, because then all we would need is x-rays or MRIs or even our examination. You go into the doctor, he'd poke and prod you, and he'd be able to tell you right off the bat where your pain is coming from. It would be consistent and predictable in who is and who isn't experiencing pain. And we know this isn't true. For sure, from the clinical realm and usually from our own personal experiences, that we've had, if you've ever had something like, man, why am I hurting so bad? But the doctor says that there's nothing, quote unquote, wrong. What they're saying is there's nothing physically wrong. There's no physical threats, but the pain that you're experiencing is still 100% real. You're not lying about it. But we do this stuff about assuming that somehow the picture, the image, the CT scan tells us where there's pain. And what the harm is with this is we know there are lots of people out there who have these age-related changes and they have no pain. So look at your back specifically. Disc degeneration. People are being told that their back pain is, is oozing like pus out of degenerative disc. Well, if you're over the age of 20, you probably have a degenerative disc. I'm sort of in a little bit to the right of the midpoint there now, just closer to 50 than 40 now. And if someone took an X-ray or MRI of my back and said, Dr. Cuccaro, your back looks pristine. There is absolutely nothing out of the ordinary there. Or I should say, it looks just beautiful. That would be weird. That would be like me looking 5 years old in the outside with a full head of hair and no wrinkles on my forehead, because I would expect to have age-related changes in my back. And over and over again, we see these age-related changes and they don't correlate. These are not pain pus oozers. Now, we don't ever ignore them, but they're just telling us that this stuff that's normal, the older that you get, the more likely you are to have it. And that doesn't tell you that there's pain pus oozing out of it. Other ways to think about it is pain actually oozed from the body like pus. It would be so easy to treat because all you'd have to stop and do is cut or poke or pop those pain pus pathways. There were actually pain receptors that had pain nerves that would send pain sensations to the brain. Then treating pain would be so easy, and we would have very predictable and sustained results that lasted, not weeks, not months, but decades and years, because we would stop the flow of it. And does this actually take place? And the answer is no. Even you look at injections for back pain. Now, one of the things I didn't tell you is that you cannot get any more pain training than I had from in the physician realm. I'm an interventionally trained pain specialist. I did all these injections and I stopped doing them because when you look at the data and you take the moment to actually look over and over and over and over again, what we see from the reviews is that they're not working. So this was one of the more recent ones. There's actually been two since this. This was published in 2015, that when you have people who aren't paid to do these injections, they look at the evidence and they look at the long-term outcomes, we can conclude that at least for chronic pain, so pain that has been there for years and years and years or months and months and months, these surgical interventions, these injections, et cetera, have no evidence to support them. In fact, they have massive amounts of indirect effects that are associated with them. That's another talk. What about surgery for back pain? Well, if you look in the surgical literature, when it comes to low back pain that has been there for long periods of time, that is not associated with things like broken bones, like bones that have been broken recently, or cancers in the spine or infections in the spine, the spine surgeon literature doesn't even tell you who that works for. That no subset of patients with chronic low back pain could be identified for whom spinal fusion is a predictable and effective treatment. It is worse than flipping a coin on whether or not someone would get better. And yet we have more spine surgery done in this nation than anywhere else in the world. Something is wrong. And if you look at our current treatment model and how we're approaching pain, it's this understanding, this fundamental misunderstanding of pain, that we assume that pain oozes like pus out of structures when it doesn't. No pain oozes like pus, whether you broke your leg or you've had 40 years of back pain. But what we do on the physician side, we get MRIs and x-rays because we're trying to find the pain pus generator. We want to say that your pain pus is coming out of your spine wrinkles. We do procedures that are trying to stop the flow of pain pus. And we'll say, we're going to find, quote unquote, where the pain generators. We're going to burn the pain generator. It'll stop sending the pain signals. That doesn't work. And surgeries, again, for back pain, when we start fusing and decompressing or putting rods around age-related change. We're surgeons, we're like trying to do like massive facelifts like you would on the exterior, on the interior, but instead of trying to look pretty, we're saying that's going to treat your pain. That is increased. And if you have age-related change on an x-ray, your physician is more likely to prescribe you opioids than if you don't. And this all comes up to this understanding again that somehow, or this misconception that pain oozes like pus out of a structure, because how else can someone hurt? And we see this is what we get for it. Despite doing all this stuff, assuming that pain it oozes like pus out of structures, we have more and more complication rates, more and more disability, more and more expensive healthcare, pulling away resources from where other areas that could be utilized, and we're not seeing people get better. In fact, our long-term outcomes with pain have progressively gotten worse. So maybe our model needs an update. Maybe we need to move away from the 17th century thinking that pain oozes like pus out of a structure, which is really way back to René Descartes in 1684, and move into and start incorporating an understanding of modern pain science that recognizes that there's a lot of stuff going on when we're experiencing pain, that pain is important, that is vital for survival, but it doesn't ooze like pus. Instead, it takes lots and lots of input coming together to what we would call construct an experience of pain. And that's key pain concept number 2, is that pain does not, there is no pain that comes from the body, whether it's a broken leg or 40 years of back pain. All pain is constructed in the brain. And how we construct pain, if we kind of go back, well, it's an unpleasant sensory and emotional bodily experience. Well, we know that there is this attentional aspect. So where you direct your attention, how you perceive things to be, is it a threat or a danger? How the sensations that are coming up from your body. So what are the characteristics and location from that sensations coming from your body? Is it hot? Is it cold? Is it in your foot? Is it in your toe, in your back, in your hip, your thigh? We know that there's association with memory. Kind of think about that. If you've ever touched a hot stove in the past and you burned yourself as a kid, why don't you touch hot stoves in the future? Well, because that memory, what you've learned, has been ingrained in such a way that you know that pain actually experience is protecting in the future, because you've realized, hey, hot things are in the past. This occurred to me. I'm going to use that memory and I'm going to stop touching hot stoves in the future. In fact, if I'm walking around, all of a sudden I hit something, I'm going to have a really quick reflex if I'm around that hot stove, because I remember what it was like when I was 5 years old with that cast iron stove. So there's this memory, the mood, the meaning of sensations, whether it's hot or cold or burning, or if it's icy versus compared to burning, like we talked about with the hot and cold metal bars. The immune system actually plays a vital role in how we construct pain, these immune modulators. So all these inputs coming together in order to construct an experience of pain. Now, this seems very complex, and it absolutely is. But what we need to be able to do is then take all this complexity and simplify it in such a way that makes sense, that's true to the science, but is also useful. And so what we can do is we can take all these inputs and we can simplify them into 3 major categories. There's the sensation. This is all about sensing things from the body. Where is this? What is this like? Is it in my toe? Is it in my back? Is it in my hip? What are its characteristics? Is it hot? Is it cold? Is it pressure-like? Is it sharp? All that provides information to the brain. Then we have the emotion, which is the meaning. What does this mean to me? Because the same sensation with a different meaning can have a dramatically different experience. Again, a burning sensation in your mouth for one person could be a wonderful experience, someone who loves spicy food. But another person who hates spicy food and has a burning experience associated with their mouth, but because they accidentally bought a pepper in a new food item, that's going to be a very different experience. Same sensation, same receptors that are involved, same inputs from the mouth to the brain, but different meaning behind it. And then we have the cognitive element, this perceptual element, the attention and appraisal that says, does this even matter right now? Or do I have bullets flying at me? Or do I have a saber-toothed tiger trying to run me down? Or do I have a bus that's going to barrel me over because I haven't been able to get out of the road and is running the red light? What should I do next? And it is only when you take these 3 primary modulators, or I should say 3 primary elements, that come together to construct an experience of pain. Now, this might seem confusing, but there's a group of individuals who are so good at this, who would be fantastic pain specialists with just a little bit of the pain science background. Those are firefighters, because every fire out there is what we call a constructed process. Fire doesn't magically spurt out of wood. It doesn't magically spurt out of oil. Instead, every single fire requires fuel, oxygen, and heat. And how then fires uniquely change, and why fires are so dynamic, is because those 3 different elements come together in different ways. And you can have the same 3 elements and you can put them together in a different way, and the treatment of those elements then changes. So if you have a big stack of wood out in the middle of a field, that's going to be that kind of fire, wood burning fire, would be treated with water directed at the base of the fire. But if we had that same amount of wood and then it was in a different shape, say that of a house, how we direct the water is going to change. It's actually going to be directed at the top of the house in a generalized cooling effect. And so what firefighters have recognized is that with this dynamic process, all you need to do is start pulling out what's the fuel source, what's the oxygen supplies, and what's the heat element. And as those change, how you treat those fires change as well. So now every fire is unique, and every fire is complex, but you can simplify it in such a way that we can now effectively treat those fires. And when it comes to pain, we can break it down in the same way, that every pain is constructed, and there are 3 primary dimensions to every pain. There's the sensation: hot, cold, sharp, dull, pressure-like. Those are sensations. And what that provides you is also a potential location, where in the body it is. But that sensation alone is not pain. Instead, then we have to add on the oxygen, which is the emotion. What does that sensation mean to me? How unpleasant and awful do we perceive this to be? The fastest way you can make pain worse is to associate awfulness. This is horrible. Flooding in all that awfulness is horrible. I have no control. That feeds even more oxygen to a pain fire there. And then the heat element is what I call cognition. We can just think about the thinking and the attention to kind of simplify it down a little bit. Should I pay attention to this? What else is occurring right now? What do I expect to occur? And so that cognitive element, that what we call appraisal, is this a threat or is this a challenge? Is this dangerous or not? Is there something else that's more dangerous or more important to me right now or not? Has an impact on our experience of pain. But you have to have all three of them. And as we change these, then these pain fires change as well. So if we look on the oxygen supply, we talked about that a little bit. If we increase the fear in loss, we can increase an experience of pain. So if we have your stomach, and then we take your stomach and we stretch it. Well, if you stretch your stomach out because we fill it with stuff, that sends sensory information up to the brain. There's usually like a, kind of a bloaty, kind of gassy sensation, really a fullness that goes up to the brain. But that sensation, again, alone is not pain. Now, because of that change in sensation, you have a little bit of heat. You have some attention that goes down and say, oh, what's going on in my stomach? Then you look out on the periphery and you see relatives that you haven't seen for 6 months, or maybe you only see them once a year. You see a half-eaten turkey corpse and 16 pies, and you had a piece of every one of those pies. And you go, well, this is Thanksgiving. And that bloated sensation is your stomach that you overate with. And while that may be unpleasant, most people wouldn't say that's painful. In fact, it may not be painful enough that you may do it every year. Now, if we have that same bloated stomach, though, and now we don't know why. It's not Thanksgiving. We don't know what else is occurring. So we go and see our healthcare clinician, and they say, I don't know why either. So now we have a lot of uncertainty, some more heat. But we think, it might be cancer. So let's go to get a CT scan. We have changed the meaning now. So that same sort of bloated sensation now has a lot of different heat, different attention to it, and a lot different oxygen because the meaning has changed. And that experience now is much more likely to be experienced as pain rather than something else. So as we change this stuff, and this can change very, very quickly, the experience of pain can change as well. Now, on the fuel source, there's lots of different types of fuel inputs. So some of them are associated with change in the body, and we will call those nociceptors that tell you when the tissue thresholds, when an area, this tissue is like being stretched too much. We've evolved information that says, hey, the flesh in your butt, you've been sitting on too long. Because you can't sit on your butt for long, long periods of time. If you did that, there's not enough blood supply and we get pressure ulcers. And so there are little nerves that say, hey, you've been sitting down here a long time. You may want to move. But if you're really engrossed, and if I'm doing a good job, you're not feeling a lot of sensations from your butt. If you're not, though, despite having those little change receptors sending information up to your brain, you may be kind of moving around and kind of twisting and turning because there's more sensory information saying we've been sitting too long. Now, those particular nerve fibers are also associated with temperature regulation, and as I said, the pressure and stretch regulation as well. But those aren't the only sensory inputs. Sight plays a role when it comes to pain. Sound plays a role when it comes to pain. Smell plays a role when it comes to pain. And even other sensory inputs that tell you kind of where your body is in space and time, things that allow us to move our hands and arms and eat, called proprioceptive information. That plays a role in pain. And yet all these potential fuel sources, again, all these potential sensory inputs also have an impact from the heat and the oxygen. Just like in a real fire, you get a lot of heat and oxygen, it can actually pull in more heat and oxygen and actually dry out the fuel and make things easier to burn. In the same way, your brain can actually increase or decrease the sensory inputs coming up to the brain itself. The critical point being is that fuel is not the same thing as fire. You may call something a piece of firewood, but nobody is scared to touch it, or nobody blindly assumes that there's fire that just jumps out of that particular piece of firewood. They know that fire requires the fuel, but also the oxygen and the heat. In the same way, when it comes to pain, you can't look at an x-ray and say, well, that's where the pain is coming from. You can say, well, there may be sensory inputs coming from there, but it's not the same thing as pain. And the absence of those sensory inputs. So if you have a spine like this, we can't say this person is not experiencing pain because we know there is more to pain than simply potential fuel itself. Now, some people, have been doing these talks for a long time, and people say, Dr. Carl, that makes sense for those other pains. But you know what? When people have a broken leg, or, you're just completely ignoring the body, and I am never ignoring the body. Because even with this person with the broken leg, that structure is not irrelevant. But that broken leg and all the little nerve impulses coming from it are only one of many inputs. Now, what is crucial is when you start understanding this stuff, is if you have that broken leg, we have lots and lots of fuel, there are still things that we can do to hit the oxygen and the heat to help this person with this acute pain to decrease their pain. And we'll touch on those a little bit at the end. But wouldn't that be nice to know if you're in the emergency room and someone's coming in, that there are things that you can do? You may, if you don't have an orthopedic surgeon, I certainly would want to know how a pain is constructed. So there are things that I can do. If I can't fix the bone, what other elements can I work with to help improve that person's pain? Or if it's me, what can I do to help my own pain? So maybe I had an operation, so I have lots of fuel, but what are things that I can do for myself to help with my experience of pain? On the other extreme, if we understand this stuff, the normal imaging, and when the quote unquote tissues look fine, is not confusing. Then all that tells us, and from a medical side, it's a good thing. It's like, well, we don't have any huge, big badness in there. There's no cancer. There's no infection. There's no broken bones. There's no autoimmune processes. Those are all good things to exclude. You can still hurt. You can have severe pain, but now we have to look at other potential threats that may be there. And when we find those threats, then we can give them the attention that they deserve to help to improve that pain. So we're never, ever ignoring the body. But when you understand pain, it crosses the spectrum. It makes sense for acute pains, broken bones, bullet wounds, car accidents, and it makes sense for these chronic conditions when you've had pain for long periods of time. So key pain concept number 2 then, pain is constructed, it does not come from. And the whole idea behind this is to start evolving our thinking from 17th century. We don't do bloodletting anymore. We don't do leeching as much anymore. We do leeching for specific scenarios. We don't do humoral theory anymore because the science has changed. And when it comes to pain, it's the same thing. It means we need to start looking at pain like firefighters rather than plumbers. So when we reflect on this, if the purpose of pain is protection, you know, pain is this protective experience. Very important. Again, it's unpleasant. We don't like it, but it serves a role. If you don't experience pain, bad things occur to you. You touch burning hot stoves, you don't remember it. You touch them again. You may have wounds in your feet that get infected and fall off. You know, leprosy. You know, people know leprosy from the movies, and it's a horrible condition. But what leprosy does is it removes fuel when it comes to a pain fire. And because you no longer have fuel to burn, now when you get nicks and cuts in your feet, you get infections, and that's what causes the flesh to rot away. It's not the disease. It's the absence of that fuel for a potential pain fire. So pain has an absolute protective role here. And if we understand that, rather than thinking about it as a damage indicator, then we then go, well, what is the primary modulator of pain? And that's threat. So threat and danger is where we see these big switches with pain. Is it physical threats like broken limbs and lots of danger signals up to the brain? Or is there physical threats around you, like someone has told you that this is really dangerous, or to expect something horrible to occur to your body? Those are all potential threats. Now, when we understand this on an individual level, though, if we know that pain is moderated by threat, then this also returns a sense of control about pain, because now we know what to do to help improve pain. And that is help to feel safe, increase a sense of safety, or decrease a sense of threat. And again, there are many, many, many different ways to do it, because like we have 3 primary dimensions of pain, each of those dimensions now are places that we can target to increase a sense of safety or decrease a sense of threat. If you hit your thumb with a hammer, there are nerves that are sending information saying the tissue's changed down here. Those little danger signals go up to your brain. What do we tend to do? We'll often grab that finger and start to massage it. What that does is that changes the sensory input. We replace that with a different sensation, a safer sensation. From a cognitive element, that's also something that we control. So the more in control you perceive yourself to be, the less threat there is. So we're already doing 2 things there unconsciously to decrease a sense of threat from the thumb that decreases our experience of pain. Meaning, what does an experience mean to you? So if you think pain equals damage, then what does pain become in and of itself? The experience of pain becomes a threat. So when you're looking, or if I'm working with physical therapists and they'll tell me, oh, my pain patients are non-compliant, they don't want to do the exercises. I don't ask them, well, how did you explain the exercises? I go, well, what did your patients believe to be true about pain? Because if you believe that pain equals damage, and then you go and someone tells you to start exercising, and now you start exercising again and you experience more pain, why would, and you're thinking, this is causing more harm to my body. Why would I do this? No one would do that if you believe that to true. But if you understand pain as a protector, this changes things. Because if you haven't moved your body in a long period of time, you're going to have some muscle atrophy. You're going to have areas of tissues that haven't moved for a long time. If tissues change, they send different inputs to the brain saying, hey, something's changed down here. Is this something that you wanted? So now you start to move. Now those same tissues start to change. Now they send sensory inputs of the brain saying, hey, things are different down here. This is kind of a burning, achy sensation because something's different down here. But now you know, hey, pain is not damage. And you go, well, I'm sore, but I'm safe, but I can still move. So even though I'm experiencing some pain, it's not that bad, because what I know it is my brain trying to protect me. The tissues are starting to change. They're sending up some danger signals. All it may need to do is back off a little bit, but the more I exercise, the more this can improve. And that's one of the reasons when we look at things like back pain, the number one primary, the evidence-based modality that prevents recurrence of back pain is exercise. But when we look at, we pull through that data, it's not how much stronger people's backs get, although they will. It's not much how much a better range of motion that they have, although they will. Is that we see a reflection in an idea that those sensations no longer have those threatening beliefs behind them, that they feel stronger. And the more strong you feel, the more safe you feel, the more likely you are to move, and the less pain that you're likely to experience. So if the brain constructs pain from 3 primary dimensions, then what dimensions are important for any pain? And the answer for this is all of them. All of them. So if I'm talking to medical providers, again, understanding pain is as important in the emergency room as it is in a chronic care clinic. Because if you have someone come in with an acute injury, lots and lots of fuel, there are things that you could be doing with your words, your actions, your voice, your behaviorisms to provide them support while you're trying to get additional care that they need. Things like calm voice, redirecting attention, increasing a sense of therapy, reassurance, positive expectations. All these things that we typically will do unconsciously are actually therapeutic. How much more powerful would it be if we focus and use them consciously and aware rather than unconsciously? And the same thing when we look at people that have had pain for decades or even longer. When we understand how this threat construct works, we can start directing attention to those threats in such a way that people can get better. And so if the brain constructs pain from 3 primary dimensions, what types of threats are important for any pain? Again, all of them are important. So someone with a broken leg in the emergency room, if that person has threats, say now that they're at risk of losing their home, maybe they lost their job with COVID, maybe they have all these other psychosocial stressors, maybe that they were trying to see their mental health therapist for a long period of time, but they haven't been able to do it because they lost access. All of those dangerous threats, those perceived threats, are important for that person with the broken leg. So while you're giving them care, maybe we're casting the broken leg, how can we assuage those threats as well to optimize care for that individual? In the same way, if people have had pain for decades and decades and decades, go, well, what are the other threats that are involved? What is the meaning of this experience for them? What have they been told 50 years ago about their back that may or may not be true? How can we de-threaten or reframe or rechange these meanings in such a way to provide meaningful change for the individual? So in summary for this particular presentation, the not so secret of pain and pain care is we do a very bad job in our healthcare systems. We typically approach pain from misconceptions when it comes to the science of pain. We poorly understand the science of pain and don't incorporate it into our care models. We view pain as a pain pus generator, ooze-outing of structures. And if we can't find something to do there, then it must be something that's all in your head and it's going to be there forever, which is not true. Instead, if we start looking away from pain and pain pus and understanding that all pain is about protection, broken leg or 40 years of back pain, and we understand then the key modulator of that protection is perceived threat, it changes the game. And when we layer that on to understanding pain as a constructed experience, we start thinking like firefighters and not like plumbers, everything changes. Because now we're going, well, what threats are important to this pain? If it's my pain, what threats are important to this pain? I hit my toe, I go walking across the road and smash it into the wall. Why am I experiencing pain? Well, I hit it against the wall. But what else would make this pain worse? Did I sleep good the night before? Where am I directing my attention? Do I have had a stressful day or not? All those inputs are going to play a role. How can I help this person feel safe? If it's me. What do I do for again, in an acute scenario, what would I do? How can I increase a sense of safety? How can I reassure myself that things are going to be okay? If I had a recurrence, because yes, Dr. Cuccaro does get pain. And if I've had a flare of back pain, because I had an episode when I was 24 that has in one particular area of my back that'll tend to flare much, much less now that I know. But when it does now, the first thing I look at is, well, what else is happening? What other potential threats are occurring in my life right now? And being able to see their contribution to that experience of pain. So how can I help this person feel safe if I'm working for somebody else? How can I help myself to feel safe if it's me? So the overall goal for this particular presentation is to make sense of pain, to move away from this idea that we're talking about pain pus that's oozing down pain pipes and pain pathways and things. This is 17th century thinking, and moving instead into an understanding the 21st century where how is this pain is constructed. And that again is the goal for this. When you can start seeing things as a constructed experience, that's when things start to change. Now, if you have questions for me, I'm going to open it up. We are down to a few, so this should be really easy to do. And a really classic one though, people, what do I do next? Well, as I said at the beginning of this presentation, this is all about the start. This is not the end, okay? If for somehow you can come into a presentation that's an hour and 20 minutes long, and all of a sudden everything completely makes sense, well, that'll make me feel really good. I don't expect that to occur. Instead, it's just to start questioning our own beliefs about pain. What have we been told? What's true? What isn't? What's actual based on fact? What's not? What makes sense? What doesn't? What other threats have not been appreciated? So we start questioning our individual pain beliefs. When it comes to care, more into what we call an active over passive realm. So passive therapies are things that are done to us. Injections, surgeries, medications, acupuncture, manipulation, anything that somebody else does to us that we don't have control over. When we look at long-term gains for chronic processes in this situation, pain, their outcomes are not good. Either they're temporary or they have worse long-term outcomes. So it becomes this, what can I do or who can I work with? Those things are going to be key. That's why exercise, cognitive behavioral therapy, ACT therapy, things that bring a sense of control and provide us the tools and skills we can use and grow with is where we see the big changes with. Moving away from management, management for pain instead to a mastery focus. People can get better. It's not super easy, but with work, it can occur, and people can do this. And rather than selling people short and saying they can't do this. As I said, in our community groups, we have people that have had decades of pain who've incorporated some of these skills and have done really tremendous things. And then focusing on what we call distress management. If you are under stress and your pain flares, that makes sense. And rather than saying, well, stress plays no role in my pain, any individual, if you are stressed out, if you haven't been sleeping, if you haven't been eating well, if you have really complex family dynamics, or if COVID has gone doing crazy things in your household and we're scared because of an unstable world, all of that distress matters when it comes to pain. So then what can we do to start managing that distress, to start mastering our stress in such a way to return a sense of control, to identify the things that we can control and the things that we can't, and separate those and focus on the things that we can and reduce the influx of the things that we can't. And with that, I'm going to open up for questions, and I'm going to stick around until about 2 o'clock. So we've got a good 7 minutes here, unless we have people asking a lot of questions. So I'm going to allow you guys to unmute yourselves if you want, or you can put them in the chat box if you have any questions. And here we go. So question away if you have them, and if we don't, no big deal. And if you can't unmute yourself, you can put it in the chat box and I will unmute you. I can unmute you. Or you can put the question in the chat box. All right, well, I'm not seeing any questions. I'm not having any questions from anybody. So if you do have questions, you can send them to me directly at drkevin@straightshothealth.com. And I'll do my best to answer them if they're appropriate. And if there is also a program that I have at whywehurt.com that provides similar information that was covered today. And you can go and enroll there, and it breaks down some of this information well. There's some worksheets as well. And someone's saying question. So question, question, question.
Thank you. So I was listening to what you said about PTs, because my dad is bone on bone with his knee, so there is pain.
Well, if he says he has pain, there's always pain.
Yeah.
Well, the question they asked, though, when we use the word bone on bone, is how many people who have bone on bone that don't have pain? Because there are people who have bone on bone and don't have pain as well.
I didn't know that.
Well, and that's where having a really good medical clinician is useful. And unfortunately, that becomes very challenging. What I would say, though, was when you're looking at any sort of pain, there's always more than just the physical structures. Okay. If he's working with a physical therapist, and the physical therapist should also be working on strengthening his knee, and at the same token, be introducing some concepts about pain. How can you feel safer again? Graded or paced movement. So you don't run out and try to do everything in your knee right away. If they're working from a surgical perspective, maybe sometimes they're like, well, we want you to go to physical therapy, do strengthen before a knee replacement. Again, when you kind of help them to understand is these movements are going to help them afterward, or that you can hurt, but it's not causing you harm, that can provide benefit as well. So, but that's the Aaron. Thank you for
It's Eigel.
Eigel. Sorry about that. Thank you for that comment. But again, there's people who have bone on bone and they don't have pain. So there's always something. Just like we're never ignoring the body. Okay, like I try to be very clear on that. We are never ignoring the body. In the same token, though, we're never saying it's always about the body.
It also has arthritis in it. That's one of the big problems too, is pain from that.
And I'll use the same information on that, is because when we look at arthritis, and we're typically, there's different types of arthritis, but the one most common is what we call osteoarthritis, which is sort of misnamed because arthritis assumes what we call inflammation. And osteoarthritis is more about like the wrinkles. It's age-related change. And again, when we look at the x-rays and we look at the long-term kind of data associated with that stuff, there are people who have osteoarthritis and lots of pain, and there are people with osteoarthritis who have no pain. So we're always looking beyond simply the body. Again, never ignoring the body, but we're always looking beyond the body when it comes to an experience of pain.
Okay. Do you have anything else?
Well, when they did what was that thing they did? Ultrasound on it, it showed the arthritis had like strings through it, and because I had a cortisone shot in there, and which didn't help, it made it worse, and more made it hurt more than what it did before I even had the shot. So I don't know if what didn't do what it was supposed to, or what the heck went on.
Well, I would the questions they're asking is, again, focusing on things that you can do for yourself, like what kind of movements can you do? How could you make a movement less threatening? How can you start slowly to build up your muscles around that knee and start moving them again are key, rather than the things, anything that people do that takes away control generally is not good for long-term care when we're looking at things from a pain perspective. Now, there's another question in here.
Yeah.
It says, what to do for chronic pain when causes can't be determined? And This is why I recommend to go away from what we call causative thinking. Like, oh, the pain is coming from the degenerative disc, or the pain is coming from this. Instead, if you kind of think about it like a firefighter, the difference is there from a medical system side. When they can't determine a quote unquote cause, that's actually a good thing. Because the causes that people are looking at, is something broken? No. Is there an infection? No. Is there cancer? No. Is there a autoimmune process where your body's attacking itself? No. Those are all things that we can eliminate relatively quickly in the medical system. And in the absence of that, if those things that I call badness aren't there, then it comes down to questioning pain beliefs, again, moving into those active modalities, focusing on things that you can do for yourself, moving into more of that mastery focus. And these are things like, again, movement is a very strong one. There's a reason things like mindfulness can be a profound role. I usually frame that in a different way because people just think they can meditate and all of a sudden their pain's going to be gone. Instead, you're using mindfulness to focus on specific aspects. I would enroll into really good pain groups. Again, with COVID, has sort of caused some problems. There's a number of them in our community that are pretty good. So Lebanon has the MAPS program, Movement, Mindfulness, and Pain Science, which I think they might be doing via Zoom. Lynn County Mental Health has the ACT, AACT, Beyond Pain program with Tina Corey, which I think they're also doing that over Zoom. There are some apps that are becoming more useful for the caring of pain. One's called Curable, which is a very, I don't like the name, but it has some good information in there, even though their pain science isn't quite totally up to par. But you start looking at the things that you can do. What are the beliefs associated with it? What is the meaning I'm giving these sensations? What are the thoughts, the threats, the memories that I have? And for a 1 hour talk, again, for a 1 hour talk like that if everything came clear and made perfect sense, that would be fantastic. But it's not, if you've had pain for decades, really take some kind of deprogramming or deconstructing, or to take this stuff and to pull out, well, what are the actual sensations that I'm experiencing? What are the memories that I have? What are the moods? What did people tell me? You know, I had a patient who in 1977 had a single x-ray of his back. And with that x-ray, what his physician told him at the time was, you know what? In 10 years, you're going to need surgery. In 20 years, you're going to be off of work. In 30 years, going to be a wheelchair. From one single x-ray, at least from the story that the patient reported to me, that's what he was told. And what happened was within 10 years, that guy had a surgery. Within 20 years, he was no longer working. And he looked at me and said, you know, the only thing that hasn't happened yet is I'm not in a wheelchair. Well, he had age-related change. He had, you know, things like looked like arthritis. He had some degeneration in his back, but he had nothing that would suggest that he would ever be in a wheelchair or anything like that. So, but when you have someone who's told you your pain is coming from X or this cause in your back, what that does from a pain perspective is it makes your brain very protective of that body part. So you have an episode of back pain. Someone tells you it's coming from a bulging disc. Now, what have we done? Our backs are perceived to be vulnerable. And so any sensations that we have coming from our back, we pay more attention to. We view them in a more threatening way. They tend to experience more pain. We decrease our movement associated with them, and they can get worse and worse and worse. Now, sometimes this seems like, oh, Dr. Carl, you're saying that this is all like in my head. And I'm saying, absolutely. Pain is 100% real, but it's 100% in your head, just like every other bodily experience that we have. Like if you think about love, if you are in love with someone, where do you experience that? You experience it in your brain and body, right? You get warm and fuzzy. Your heart starts beating faster. You have blood flowing in different areas of the body. But that experience is just very real and very physical, and actually changes the physiology in your body, changes blood flow, changes endocrine secretion, all that stuff. So there's a very real process to that experience. It takes place in your brain, which is, you know, if someone had a heart transplant, they don't fall in love or divorce their spouse because they don't love them anymore. All that stuff is taking pain in the brain. And all of that stuff has an impact on the body. And when you think about pain in the same way, it changes the game. We tend to default to thinking pain is all about body damage, or it's not. And then we say, well, those people are making it up. And that's not true. All pain, any pain, always has body information and all the brain stuff as well. So from a medical side, you want them to eliminate all those things, all those bad things. If they say, you know what, we don't know, quote unquote, the causes, to me, that is a good thing, because what that tells you is it's not cancer, it's not a broken bone, it's not an infection, it's not an autoimmune process. And in the absence of all those, that means that there are things that I need to do. So it means, do I need to move? Do I need to change my diet? Do I need to pay attention to my sleep? Do I need to start doing a pain journal? You know, all those other things become that are things that I would directly control, or where I'd put my focusing my efforts on. All right, any other questions here? We're at 2:04. Okay, I am not seeing any more. I will send this recording off to Samaritan, and I will let them do what they want with it. They either publish it or not. For everybody else here, thank you so much for being on the webinar today. Sorry for the confusion that came up front when you're not part of the Samaritan team. Their platform doesn't like us, but hopefully you got some good information in here. At least it starts the journey for you, because there is a lot more to pain. There's a lot more excitement. It does change the game, though, because instead of seeking someone else, some other clinician is going to be the reliever, it really comes down to the things that we can do for ourselves and to utilize those in a way that provide us benefit. And there's some exciting side effects of that as well, but that's for another presentation. So take care, everybody. Stay well and stay safe during this day and time.